eminent speakers, extremely experienced people who will be all talking about various issues in public health. We have first Dr. Amit Sengupta, who will be talking on unpacking UHC and its implication for healthcare. He is trained in medicine and he works in issues on public health, pharmacy policy, pharmaceutical policy, and he has been with the Delhi Science Forum for a long period of 28 years, and also with All India People's Science Network and Jan Swasthya Abhiyan. He is the co-convener of the global network People's Health Movement India, and is the associate coordinator of the People's Health Movement Global. He was also the coordinator of the World Social Forum when it happened in Bombay in 2004. Among a number of other publications and articles and books, he has also edited the Global Health Watch to 2011. So first I invite Dr. Amit Sengupta.
Thank you. And it's really a pleasure to be in Bangalore, especially when you are coming from 45 degrees in Delhi. So it's good as a bonus to be speaking in an audience like this. Now, what I'm going to try to do, and as quickly as possible, is to tell the story of universal health coverage, to get the terminology right. And the terminology is important, as we shall see as I tell the story. I could have done without a PowerPoint. My relation with a PowerPoint at best is whimsical. So, pardon me if I don't follow what we see on the screen. But essentially, this is going to be a fairly meandering presentation, looking at how things have developed over the last decade or so, on a discourse that now seems to dominate all discussions on health. So UHC, or Universal Health Coverage, is the flavor of the day. So no discourse on health is complete without the UHC, and it's used almost in all documents across the world. So the issue also is that UHC means so many different things to so many different people. So that's why I thought it would be nice to look at the story from how it started. And one of the starting points, and there are several starting points of a story like this, but one of the starting points is possibly a small resolution that was passed in the 58th World Health Assembly in 2005, which you can see there, the operative paragraph, which talked about ensuring health financing systems, including a method of payment, etc., with a view to avoiding catastrophic healthcare expenditure. So the key words or the key phrases in this beginning of the story of UHC were health financing and catastrophic expenditure. These, in a sense, encapsulate what UHC was all about. So the conceptual underpinning was health financing, and the urgency was provided by catastrophic healthcare expenditure. So the first point that perhaps is important to understand and underline here, that it arose as a method of ensuring sustainable finance, and not with a view to address the precise mechanisms by which healthcare would be provided. That is something that we need to really take note of. Now, let us look at why catastrophic expenditure of healthcare became such an issue by the beginning of the of this millennium. Just to be technical, catastrophic health expenditure, as many of you know, is defined as when the total amount that people pay on health care exceeds 10% of the consumption expenditure of the household. So that's the technical definition. But essentially, what it embodies is a situation when having to pay for health care leads to situations where populations are pushed below the poverty line, pushed into penury, pushed into destitution, and there are various figures floating around. There are figures for India which suggest that every year you have something like, again, there's a range, but from 3 to 7 million people who are pushed below the poverty line only because of expenditure. But this basic point is that this is something that is a global phenomenon. It's not restricted to India, it's a global phenomenon. And it is possible to trace the genesis of this phenomenon to sometime in the 1970s and the economic crisis then of the 1970s, which essentially, like all economic crises, the economic crisis has to do with money, and so it starts with countries which have money. So all economic crises in the world have started with the rich countries, including, for example, the financial crisis. The 70s economic crisis was actually a crisis that started in the United States. But quickly, as again happens with all economic crises, the impact was transferred. And I say all this with a lot of hesitation, even if it may not sound so, in a hall which has a lot of health economists. So I'm using a lot of economics terms rather lightly, but you pardon me for that and probably haul me over the course later. But to continue my version of the story, there was an immediate or a very quick transfer of the impact of the 1970s economic crisis to countries in Africa, Latin America, and Asia. And one of the major elements of the transfer of the economic crisis of that period was savage cuts in public expenditure. And that included cuts in expenditure in the social sector. And this was something that was very actively and aggressively pursued by the Bretton Woods twins, the IMF and the World Bank. And these were, the cuts in public spending were seen as fundamental to poor countries receiving loans to bail them out of the crisis that they were going through. Now, this also led to the banks, the World Bank's health sector reforms. Is a very important document that comes out in the period called Investing in Health, 1993, the World Development Report, which some of us had called the disinvesting in health. But it was part of a major move to suggest that profligate public spending in poor countries was the reason why their economies were in crisis. Now, I'm not going to go into how right or wrong they were, but this was and you had the infamous structural adjustment programs in that period. Now, essentially, the entire package of policies that were pursued in much of the developing world, starting with Latin America, spreading to almost the entire continent of Africa and to large parts of Asia. The entire package was really designed not to strengthen the public system, if I may put it that way, but to find ways in which the governments in these countries could reduce investment or reduce any form of public expenditure on acknowledge that some of the major reform that were introduced included ceilings on public health expenditure, cost recovery, the famous again, user fees that spread like prairie fire across the, especially Africa, and significantly, which I shall come to later, a segmentation of the healthcare system into the public and the private, which I shall look at later. Now, what did segmentation really mean? The discourse of, so as I said that UHC is the flavor of the day today. The flavor of the day in the 1970s and 80s was targeted care with minimum packages for the poor. And the logic that was really applied was that given that public finances are limited, so governments do not have an option of trying to provide care to everybody, and so it is better to target care for the people who need it most. On the face of it, very a logic that would seem very reasonable. But what it did to public systems, and this is not something that it did in one country, but across the world, in country after country, across continents, was that it meant that people with resources, the rich, the elite, chose to opt out of the public system. Because the public system became targeted minimum package for the poor. And as the elite came out of the public system or withdrew from the public system, they also, along with it, drew away resources and accountability out of the public system. And along with that, we see the void being filled by a rapid expansion of the private sector. So this is really what one can see from the 70s right down to the 90s. Again, a global phenomenon. And you had, of course, the private sector largely unregulated. Again, this has been a major conundrum that the private sector, and no country in the world has actually been successfully been able to regulate the private sector, because when we all discussions about utilization of the private sector are accompanied by issues about that you need a regulated public sector, but we also need a debate on whether at all it is possible to optimally regulate a private sector so that it is within the public ethos of public health. In fact, I was, when Mr. Girinath in the beginning talked about universal public health, I found that quite interesting, because I wish the discussion was about universal public health. But unfortunately, we are yet to arrive at a situation when it's a discussion about universal public health, and it's really about a different animal that we are still trying to. So anyway, so you have the private sector growing and helped along by direct and indirect subsidies by governments again. Now, for example, if you look at India, something that is very rarely talked about, that you have the huge and today corporate, you have tractor manufacturers and others now who are big players in private corporate healthcare. Now, we seldom really look at, for example, the indirect subsidy that is provided to such institutions by one single factor, which is human resources. Even today, and in spite of private medical colleges now being about 40% of the total number, the best medical colleges are still in the public sector. And a majority of them today work in the corporate hospital. If they somehow do not escape to the United States or Europe. So the point really is that there is this huge subsidy of public education that today goes to subsidize the private corporate. There are various other, many of you would be aware of for the last decade and a half, the Delhi government has been grappling with attempts to rein in the private hospitals and making sure that they do not renege on their promise of providing free care to 25% to 25% of the hospital beds, which was a promise made based on the fact that all of them got land at something like 1 rupee per acre. So these are the kind of, and there's a host of, as one can leave, in terms of tax benefits that the private sector gets, in terms of imports of equipment, medicines, etc. Now, so this is the situation that we were in the 80s, 90s. To recapitulate, it is a situation where, because of withdrawal of public resources, public systems had almost had faltered or almost been decimated in many parts of the world. It was a situation when the private sector had expanded enormously. It was a situation where governments found it impossible to rein in costs that people had to pay for healthcare. So that is what was catastrophe. Now, what is interesting in this debate is the same set of actors which initially were responsible for creating a situation when catastrophic, and I'm using their terminology, expenditure led to widespread destitution and ill health. And it was the same set of institutions, global as well as national, which then provided the path for rescue, which was bottled in what was called universal health coverage. Now, if I may, take a slightly side path, it is interesting that when you talk to public health activists, when you talk to public health professionals, instinctively we use the acronym UHC as universal health care, because that's how we are trained. That's how we were led to believe that when you talk about universal, it is care. But when you go out of this hall, go back to all the documents, the official documents of UHC, and try to find care rather than coverage. It was never about universal health care. I wish it was. I wish it was about public health. But the discourse has never been about universal health care. The discourse has always been about health coverage, and we shall really see how. Now, it is not as if there wasn't an option. It was not as if care wasn't an option. At the turn of the century, to be fair, there was an acceptance that the situation must change, that people requiring to pay for health care is not a situation that should continue. And logically, one of the ways of changing that could have been of rebuilding public systems. Unfortunately, the debate quickly shifted to providing not on concerns of how services are to be provided, but how they are to be financed under the broad rubric of universal health coverage. Now, this is the famous cube. You will see that again in any discourse on universal health coverage. You will see this famous cube being talked about. I'm not going to. There are people who can better explain what this cube is. It still leaves me confused a lot. But essentially, why I projected this cube is to try to find somewhere in this cube a way in which I can say that this discussion is about care, about provision of care. But as you will see, it's all about coverage. It's all about the insurance language of coverage and not about the public language of care. So this is governments as managers of care and not as providers of care. And you have what is called the classic provider-payer split, where the issue of financing is divorced from the issue of provisioning. Now, this is it's important to again stop here and think back. What has been achieved in the last 30 years, I do not say that it is insignificant. That it has taken 30 years for certain institutions to realize that finances for public health, for health care, has to come from public sources. We can, as we heard in the morning, probably that's a small victory. Now, whether those finances actually come through or not is another matter, but at least there is an acknowledgement. So that's an old debate now. The debate that public finances are required to provide public services in healthcare is an old debate, which somehow seems to have been clinched. Now, having clinched it does not mean that actually public finances are today available, but at least at the level of the theoretical debate, it seems to have been clinched. But the new debate then, really, and this is for me the core of the debate as far as UHC is concerned, is how those services are really going to be provided. Because as if we have followed the story till now, it is clear that under the rubric of UHC, it is possible to have a situation where it is entirely financed through public sources and entirely provided through private enterprises. It's possible. I'm not saying that that's what exists in many situations. What exists in many situations is a mix of public and private provision. But there is a clear opportunity that UHC provides, and UHC provides the theoretical basis now for the first time, and this is again important to understand. It provides the theoretical basis for involving in a systematic manner private enterprises, not as individuals, but as networks. So that is the expansion of universal health coverage into the theoretical domain of how provision of public services is to be done. Now, so then, what are public services, or where do they stand? Again, now 5 years after the resolution that I talked about at the beginning, the World Health Report of the WHO. Again, interesting sentence in the World Health Report which says, governments have a responsibility to ensure that all providers, public and private, operate appropriately, etc. In other words, UHC is not in this business to discriminate between public and private. UHC is in this business to manage care. UHC is in this business as Imran keeps saying, a steward of healthcare. And I'm sure Imran will talk about that later. So you have this apparent impartial role of the state that can be interpreted very differently. But importantly, it is subject to the current state of the public health services. And as our story has unfolded, we have seen that public health services in this period have actually been decimated. So then you have this very convenient logic, catastrophic expenditure, people are dying. So you have to do something. You have to do something now. Now what do? You don't have a public system. So as a logical follow-up, it says, let's get the private sector to do this. So this is really how the story unfolds. Catastrophic, keep talking about, and this is something that has, it's not India. This happened much earlier in many other countries. We are just following on today. This is the same debate. First talk about the catastrophic nature of health expenditure. Absolutely correct, not incorrect. And then look around and say, but who's going to provide services? And there is no public sector because we have killed the public sector. So let's go to the private. So this is really what we are. So there is this nice sort of transition, if I may say, from what was for us at one period a dream of health for all. Now, how many of us have really heard this phrase being talked about in the last 5 years? It's forgotten. The whole debate, the discussions, in all our discussions about UHC, we seldom see discussions which were part of the 70s, 60s, 70s, 80s discourse about public health, about first contact, about the rural health worker, about training of health personnel, about how public systems need to be owned by the community. Now these were the hallmarks of discussions that happened among public health circles. Today the discussion is about governance, about packages. Dice, slice, put them in a bowl, and we have healthcare. So that's how that's why I put this slide up. Probably at times it's important for us to also remind ourselves that there was at one time a different vision of health for all, of healthcare for all, which talked about integrated systems of comprehensive care, of equity, of community needs. Now UHC is really about bits and pieces like a jigsaw puzzle which is all supposed to come together, and you have the government playing the other arbiter. Now, very quickly, the discussion about UHC in India really came to the fore. It's been going on for some time. It really came to the fore in the lead up to the formulation of the health chapter in the 12th five-year plan, when its initial drafts were very clear about charting a course for managed care, with again the state or the government becoming the manager of care, and care to be provided by contending networks of private providers. Now, I'm not going into the entire story, but this was something that was actually opposed by a lot of organizations, and in fact, interestingly, opposition came from within the health ministry. And the final draft was diluted to an extent. But the ideological underpinning of UHC has once and for all now come to stay. And it is very much part of the official discourse now. So, different policies that now come out through different channels include this class. Now, as part of this story, we also had the high-level expert group, which included many of our friends in them. Many of them successfully were able to introduce some very useful recommendations in the HLG report. But what perhaps they did not bargain for was that the HLG report, at the end of the day when it came out, had a kind of a bomb, a kind of a time bomb which was embedded in it. Many of them which have later in private conversations that we did not even know that somehow this bomb has been, which is para 3.10 of the HLG report. So next time we go back to the HLG report, it's important to look at the HLG report in its entirety. It has very useful and convincing arguments about the way forward. But it also contained this paragraph which said state government should consider experimenting with arrangements with the state and district purchase care from an integrated network of combined primary, secondary and tertiary care. The report left it ambiguous as to what this integrated network of combined primary, secondary and tertiary care providers would be. For the planning commission, this was not ambiguous at all. And it was picked out of the HLG report, and in fact, if you look at the first draft of the planning commission, this was really only para that was quoted in full as something that provides legitimacy to what I was talking about earlier, which was the plan to have private networks of to provide care. Now we've been talking a lot about UHC and how public systems have been decimated or undermined. Let's look at what has happened to the public system in India. How inefficient is the public system? There are enormous problems with the public health system in India. But just to understand that in spite of the very major claims made about the primary of the NRHM, the National Rural Health Mission, it is a very underfunded program. It has received from the earlier promise just about 1/3 of what was promised. And it is under those adverse circumstances, this discussion is important because continuously we keep coming back to saying, but the public sector doesn't work. So we have no choice. So is it true that the public sector doesn't work in spite of the adverse circumstances it works in spite of repeated interventions by governments which do not allow it to work? The public sector today has about 20% of financing and 20% of the workforce, the health workforce working for it. Yet it provides about 33% of all qualified outpatient care, 40% of all inpatient care, and 60% of critical care, and almost 100% of preventive and promotive care. Now, very crude economics somehow tells me that working with just 20% of the finances and workforce, I am not doing a very bad job as a public sector in this country, in spite of all my deficiencies. So we need to interrogate this story further. How bad is the public sector that we seem to be trying to give up on it? Now, of course, as I said earlier, inefficiencies, corruption exists, but they are not inherent faults of the system, but introduced often deliberately in the system. And I do not think an audience like this in India needs to be educated about corruption in public health. And all of us know who introduces corruption or different inefficiencies. We all know that every promotion as you go higher up in the public system has certain political reasons. So those are not inherent problems of the public system. They are inherent problems of the way we govern public system. If you look at evidence across the world, success of health systems are clearly located in successes of public systems. Talking about Cuba, Costa Rica, Sri Lanka, Ireland, all successes of essentially public systems. And nearer home, we have clear evidence that if we look at Kerala and Tamil Nadu as states which have done relatively better, again these are states that have continued to the extent possible in investing in public systems. So there is this evidence that we have today, but somehow we do not want to look at it. Finally, what has come to embody UHC in India? This is really about insurance. UHC is really about insurance. Insurance is really about, and it's really about coverage. So we have the RSBY and the model on the Arabishi of AP, Andhra Pradesh, and various states. Now, on the face of it, a very impressive rollout within 5 years of what was called social health insurance, entirely publicly funded, which today covers about 1/3 of the country's population. One of the most, in terms of population coverage, one of the most impressive rollouts. If you discount China, it is probably the most impressive rollout of coverage by a model which provides would say UHC. Now, what was the content, or what is the content of these social insurances? Public funded, only for hospital care, with people having choice. Choice. The discourse of choice is very important in this whole discourse of UHC. So people have the choice to go to public or private, which are actually their system. Now, in practice, the way this choice translates into reality is that across India, a overwhelming majority of accredited institutions are in the private sector. The figures for Andhra Pradesh are there, but that's the story. In fact, Tamil Nadu is even more, it's about 90%. That's the story that you see. But that's only part of the story. It's not about how many institutions are part of it. It's also about what gets picked up by the private sector and what gets picked up by the public sector. And again, there is something to learn from that. And what you get to know is that there is clear cherry picking that takes place. So the private sector just draws in those cases because people today are not known as patients or people, they're known as cases, right? So those cases where you can make a higher level of profit, and the dirtier, messier cases are pushed into the public sector. That is why in Chhattisgarh and Bihar you have this whole stories that broke in the media about a year back of hysterectomies. Very easy to tell women that all their problems are related to the uterus and it needs to be removed. So you have, I'm not going into the data, I'm sure all of you have gone through that, of how the kind of malpractice that has now become integral to the functioning of many of these social health insurance schemes. So this is the real story. The ideal story that UHC would like to lead is this very nice division of public and private which work together for this nice tapestry to come together. But actually, when you really look at the kind of cloth that you are weaving, this is on the ground, the story that you see, and this is not typical of India. This is what you see across the globe of how insurance as a model of providing care, with the private sector as the medium of providing care, when that becomes so I'm not going into this except to look at what have we learned in the last decade or so about the functioning of the social institutions. I think fundamentally, and the first bullet point out there, it is about strengthening private facilities with public funding. With your and my funding, private facilities are being strengthened. The same money could actually have perhaps been spent to build public infrastructure, but we chose to use that to strengthen private and thereby further diluting existing public. And finally and importantly, distorting care priorities where tertiary care, because these social insurance schemes are really considered in tertiary care, draws an inappropriate amount of money. And yet, this is the model that we think will bring more. You will see, it tells a lot about the model of social insurance, but it tells us a lot more about what UHC is seen to be. Not what UHC is, but what it is seen. Now, I'll end the story by acknowledging that the public health system is not the public health system we want. And there are a number of things that need to be done in the public health system. We talked about corruption, accountability, etc. It's necessary to have guidelines, protocols applied across the board at different levels of the public system and ensure how equity can be ensured. A very important and aware of the place where I am sitting, of human resource gaps. One of the primary problems of the public system that we are still, or at least the elite in India, are still Brahmins, right? So the doctor who is the Brahmin has to sit on top. It's part of a mindset that the doctor sits on top of the pyramid, and that is why all our planning of human resources is about the doctor. And all our lamentations about human resources is about the doctor not going to the village. The present doctor will not go to the village. It's very simple. Why have we not learned this in the last 50 years? The present doctor, drawn from a certain class, provided a certain kind of an education, is not equipped, is not her or his fault. Not equipped to go there. Is a social misfit there. Cannot. We just heard this story earlier about. This is a universal story of children taking away midday meals so that they can share it with them. No, is the modern doctor that we are creating today able to relate to that? So, why I'm making this bit of a thing about this is that so our whole emphasis on human resources has to change. Has to change based on requirements or tasks that need to be done at various levels of healthcare, about different ways of training human resources, of doing certain tasks. And without that, the public system really does not have the ability to expand to underserved areas as it requires to do that. And finally, and I'll end here, what we are then talking about is to bring back this social logic into public health, which has been overtaken today by the logic of finance and commerce. I feel a bit embarrassed continuously talking about finance and trying to bring it back to public health. But for me, public health is about finance, but it's much more about people. It's much more about people taking care of other people. So the social logic of public systems, and now I'm not talking only about health systems, so public systems across the world, water being privatized across the world today. The social logic of public systems need to be reclaimed if we are really talking about providing healthcare with an equity lens. And finally, much of what we are talking about is now healthcare. And that's a fraction of what keeps people healthy or unhealthy. Health is finally a mirror. Whatever we do wrong or right, we see in the health of people. And a very small fraction of that is in healthcare. A much larger dimension, which we are not discussing today, is really in the domain of whether people are going to sleep hungry. The story we heard about whether people have employment, whether they have water, whether they have a roof. That is what health is. It's not just about care. So while we continue to discuss about healthcare, it's important to understand that we are really still talking at the margins, and there is this much larger world that we need to do. So I think I'll stop here. Thank you very much.
Thank you. That was extremely enlightening, at least for me, and a good start to the discussion. I think for me at least it sort of made this point that even in the health sector, this is part of the broader withdrawal of the state from everywhere. This is also what's happening in the health sector. So thank you very much for